just come back to Calcutta at that time from on my post graduation. They were all my uh, fellows in UK MRCP capacity. So I did my MRCP and then capacity I got from Glasgow and fellowship. So I just come back and this lady came to me and it looked like a lymphoma. Before that, she was treated at ENC. At that time, I was in the Apollo Hospital. ECG wasn't at Kolkata. And we had all the immunohistochemistry, which was positive. The CMAC they did was negative. Putting it in the hands algorithm, we find this is a non-germinal center B-cell lymphoma, which is aggressive, a very high Ki-67. And if the patient comes to us today, I think all of us will know, young patient will most probably get dose adjusted EPOC rather than R-CHOP in this. But yeah, we're talking about 2013, and that awareness wasn't there most probably. And so she was given R-CHOP. Interestingly, they did a interim PET scan, which was fine. So she remains well for 1.5 years, and then she relapses. And when she relapses, she has extensive disease. She was started, the whole concept of, as we know, of treating with relapsed refractory lymphomas are we try to get her to some form of remission, and we try to do an autologous bone marrow transplant. So salvage chemotherapy, RICE or RDHAP, we use a lot of salvage chemotherapies, but RICE was used, RICE, and she didn't respond to it. So she was put on a Pepsi regime and was asked to go back in 6 months. So when she came to us, this was her blood counts, and this has not come out very well. I'm sorry. I'll just say that we're in a meeting, if not urgent. Yeah. So we see there are two signs of disease. One in the chest, mainly one in the abdomen. And we thought we were going to give her a different salvage regime. So what was available at that time and things. So what we did was we gave gemcitabine and bendamustine together. And I've used it in a few other patients who are very refractory. It is definitely very toxic regime. And patients should be kept in a positive pressure room and all that. But it works. Given the combination in a young fit patient, you can think of combining gemcitabine and bendamustine. And there was a trial going on. We spoke to them to give that, and so this was the regime. So we give 2 days of bendamustine and 2 days of gemcitabine. Day 1, day 8 gemcitabine, and 2 days of bendamustine with rituximab. And after the first cycle, so now she is chemosensitive. Perhaps the time to do an autologous bone marrow transplant. And as we know, this is how we do autologous, bone marrow. So this is mainly for the students. When this is not working, we change that. So we change it with stem cells. So if you have basically cells and normal cells, we give them wheat killer, which is our conditioning regime, clear the garden, collect the seeds from the patient when in some form of remission, then give it back. So that is autologous transplant, and lots of evidence for autologous transplant still coming out, starting from early 1990s, still coming out. So as we proceed, what we try to do is this wheat killer that we give, what we want it to be is to be more effective and less toxic. And that is my conditioning regime. Most places around the world would use beam. Um, my alma mater was the Haematology Hospital in Imperial College, and there we used to use lace. The difference between beam and lace, what I found out, was the amount of mucositis which happens in lace is definitely less than the amount that happens in beam. The effects are most probably the same. Less might have some effect in patients who are not chemosensitive also, but little, some effect, not very much. So this was one of the papers again published from the Hammersmith group. And but the probability, if you're looking at both lace and beam, we're looking at around a 50 to 55% patient with overall survival and disease-free survival. Now, we need to get better in this. And also, we try to decrease the relapse and decrease chances of pneumonitis, decrease relapse, and try to get better with this. So, uh, I always tell this story. This is one of my favorite stories that during the Second World War, there was a ship full of nitrogen mustard, which was bombed in Italy from Bari. And the sailors dived in the sea and they swam. And they found that everybody was having first blisters and then they started having marrow aplasia. So the nitrogen mustard gas was working very badly on the highly dividing cells in the marrow. And so, lots of things happen. People tried to, suppress that fact. Lots of political implication was there because it was the Allied forces was carrying chemical warfare. It was not the Germans who were carrying chemical warfare. So what happened was, there was a Stuart Francis was basically needed to go and do an investigation in that. He came back, he found out that this is a nitrogen mustard gas, which Goodman and Gilman at Yale University started experimenting and brought out the first pair the Second World War. This went to East Germany, and they started experimenting with it. And what they did was they took out some groups from that and added some other purine analogs group in it, and they came out with a drug called bendamustine. In 1969, it was first used. And when the Berlin Wall fell down, we came to know that there is a drug called bendamustine. And this is the drug called bendamustine, which has got, the it looks like my cyclophosphamide. It also has the purine analog group in it. And so the question that came to mind, we started using bendamustine first in CLL, follicular lymphoma. We are now using it in everywhere. Every, lymphoid disorders, we think we are using that in Hodgkin's disease. So the question that happens is, can we use it in a conditioning regime? And this was one of the first papers that came out where they used bendamustine with etoposide. So like a beam, but apart from the carmustine there, they're supplementing it with bendamustine. And you can see that, just for over 20, 30 months, my overall survival and my disease-free survival is not bad. Definitely better than my lace or beam. And if I take it forward, and if I look at around 5 years, then we are finding it that it is, it is very much better. But there was a lot of mucositis in those patients. What we did was we did the base regime, but very, very simple, but we used bendamustine in place of lomustine. And we have done around 40 patients so far, and has been published. And we're getting, more than a 75% disease-free survival started in 2014 till now. We should be writing up a follow-up on this paper. And we are getting almost greater than 80% overall survival with no TRM, no transplant-related mortality. So I think this is a regime which we should use for doing transplantation. And what happens is that, but there are some patients who are going to relapse. And there we need to look at other forms of immunotherapy. And the evidence of immunotherapy comes from the graft versus leukemia effect in allogeneic transplant. So that is where we find out, the most direct evidence is giving donor lymphocyte infusion, and patient goes into remission and, stays in remission. So that is perhaps the most direct evidence of the T cells working against the disease of immunotherapy. And so these are the clues. So if I have a syngeneic transplant, I can see that my relapse rate is the highest compared to if somebody has GVHD, which has got a lot of T cells overworking, then my relapse rate is less. So if I do adaptive, if I look at the timeline, then in the early 1950s, when we started doing transplantation, Don Thomas at Seattle, when he started, experimenting with all this, George Mathey in Paris for, the transplantation to work, at least in animal models. And then we came out to the MHC. So Teriyaki and Wood came out with their model of MHC, And we then gradually started to discover that it is very much the immunology, the T cells which are coming along, and came to know about the TCR receptor, the T cell receptors, all the interleukins started coming along. I still remember at Hammersmith in the relapsed Hodgkin's disease, we used to give them very big doses of interleukin 2, 10 to 12 million units, and then give the DLI. So interleukin 2 would get your DLI to work even better. So, those are the things that started coming along, experimenting with interleukins and everything. And it is, in late 1990s, early 2000, that people started thinking about chimeric antigen receptor T cells. So they started experimenting on CD19 and CD20 CAR. It took a long time for the first clinical model to come. So these are the antigens where trials are going on. Some has been commercialized. 19 has been not commercialized. BCMA has been commercialized. Trials are going on, and other antigens as to how we go about. So quite a lot of studies going on CAR T cell therapy. And what we do, we basically, construct the CAR by putting in the virus in, and it'll have the domains which is going to have this is the tumor antigen domains. And I've got a signaling domain here. And then we put some other domains. So apart from the T cell signaling domain, we would also need a co-stimulation domain, so which will be a CD4 or OX40 or a CD28, and we put that domain in. In the second generation CAR, we have one co-stimulation domain, one primary CD3 signaling domain, whereas in the third generation CARs, which are now in trial, we will have two co-stimulation domains. So once that is there, we expand it and we then give it back with the hope that this CAR T cell with two kind of DNAs in it, one the viral DNA and the other its own, that's why it's called chimeric. It is going to go and attack this T cell, sorry, this tumor cell, and to cause the problems with it or kill it. But if you're talking about lymphoma, we now know that for lymphoma, there are 2 or 3 FDA-approved CARs. Is it really better than doing an autologous transplant? This is going to cost a lot of money. This is going to take time. So is it really better? And this is one of the papers which have just come out, and you can see that if I do an autologous transplant properly, then my progression-free survival in this group is around 65% or more than 60%. But the question that happens is that if we do it the way that we do with bendamustine, I'm getting at least even better than this. So what is the rationale of doing a CAR T therapy in relapsed lymphomas on the first line? I would most probably not advocate that. I would most probably still, in patients who are fit, who are eligible, would go and do an autologous transplant in relapsed refractory lymphomas. If the patient is relapsing, yes, I have my CAR T cell therapy with me to look into it after that. And this is proper evidence. And also, with experience, you come to know that autologous transplant is a very, very good treatment for most lymphomas. I must say that of late, of the 40 patients, almost 17 patients have been put on maintenance therapy for after autologous. So what we do is we give them rituximab every 2 months. Along with that, we give them ibrutinib and lenalidomide as maintenance therapy for 2 months. And that is, ibrutinib is now a generic medicine. So with that, in a much, much cheaper way, I've been able to keep able to keep patients in remission. Now, obviously, we are doing it from, let's say, 2017. The ibrutinib kind of arm came along in that study. There has been no relapses so far. So let's wait and see how it goes. One thing that happens definitely with that is more chances of viral infections. That definitely. Gamma globulinemia is a big, big issue. So I don't think anybody has CAR T cell therapy compared to if you're just going to do autologous transplant followed by maintenance. There has been no, the way we do it. Obviously, we haven't had a chance to do an head-to-head study, but this is quite conclusive that if you're going to really look into lymphoma, let's first try and do an autologous transplant. And then there are various mechanisms of keep making that autologous transplant work. I might be doing one, you might be doing one, you are more comfortable in that, but I'm more comfortable in this. But once we exhaust our options with autologous transplant, that is the time I think we need to go for CAR T cell therapy or allogeneic transplant. Today, in my ward, I have a 36-year-old lady who presented as a primary mediastinal and really big with with blocking of the SBCs and everything. She presented elsewhere. She has had lots of treatment, including glofitamab. Glofitamab is now available in compassionate basis. So that's a CD20 bispecific antibody. It brings a T cells. She didn't respond to it. So when she came to us, we gave her nivolumab with bendamustine, and that has worked very well. So she has gone into almost 95% of the mass has gone, and the SUV has come down to 2.5 from around 15 or 16. So she has responded very well, and this is the time to attempt an autologous transplant. Here, because she is so extensively treated, I don't know whether I'm going to get stem cells. So if I don't, then I'll have to think of either an allo or a CAR. I most probably can go and do a bone marrow harvest and see. But even if I can't do a harvest or anything, maybe that is the time to think about all this. So autologous transplant is an answer, but many patients will not be suitable, elderly patients. So they will not be suitable. So there, I think, CAR T plays an important. So we have to select our patients very well. Because it is a new treatment, we shouldn't rush for it. We should select our patients very well. And talking about this, I think multiple myeloma is a disease where CAR T will play a very important role because most of our patients are elderly. Most of the patients we see will be having 3 or 4 lines of treatment, including carfilzomib, including daratumumab maybe, and then they come to us, and we try to do something about them. In a young, fit, younger patient, fine, we do an autologous followed by an allogenic transplant, but that will be maybe 1 in 10,000, a young myeloma. Whereas, most of the people will benefit feel that myeloma is because of T cell exhaustion. So the reason for myeloma to relapse is T cell. One of the reasons is obviously T cell exhaustion. And if I just getting a bispecific without activating the T cell, that might not work. So we will have to have some other strategies to activate the T cells, to decrease the T regulate T cells. For example, giving daratumumab before a bispecific antibody for myeloma might work. So you activate the T cells with that, and then you give a BCMA, let's say, directed bispecific antibody. But if I have a CAR, then I have got a domain which is already activating the T cell. So I think a CAR is going to work very well in multiple myeloma. So this is where this is my CAR T cell therapy. Uh, we do a leukapheresis. We isolate, activate those T cells, engineer them with the CAR gene, or the lentivirus goes in, and then these are the membrane domains. As I said, these are the co-stimulatory domains, and this is the antigen targeting domains. Here we expand that, we infuse it in a patient, and hope that the CAR T cell comes and kills the tumor cell. So that is what uh, the graphics of it really. And if you look at the evolution, as I said, so this was the first generation CARs. It was not staying in the system for a long time, and it was so it was not staying. It was not activating the T cells. So what they did was in the second generation CAR, they added a co-stimulation ligand to it. And now in the third generation, we might have 2 co-stimulation ligands, OX40 and the CD28 or any other co-stimulation, depending on the product. So we know about the associated toxicities of CAR T cell. So early phase, we need to be very careful about cytokine release syndrome. But after COVID, we are much more confident in treating CRS than what we were not before. We have seen CRS so much now that we can realize the signs and symptoms of it. Once we were doing haploidentical transplants with the T replete haploidentical transplants, we started doing it, let's say, in the Western world, let's say 2007, 8. Initially to it, but I don't feel that CRS is a major issue in haplos because of the cyclophosphamide we did, and that kind of suppresses that CRS. But saying that, a lady, so this is Dr. Ayan Basu. Ayan is my colleague and friend, is a HOD of radiotherapy at HCG Hospital. So we do a lot of total marrow irradiation and total body irradiation in transplant, and Ayan helps me out with it. So when I was telling you that the last girl with it, Faria, she had bad CRS with interleukin 6 values greater than 5,000. So we had to use a lot of tocilizumab in that. So those are the things we need to be worried about: neurotoxicity, cytopenias, hypogammaglobulinemia is an effect with that, and many patients go on lifelong immunoglobulin replacement. Tumor lysis is rare, but we need to be worried about it. Again, infections and hypoglycemia is perhaps the most important side effect of long term. Um, whatever heard, and I've not seen delayed neurotoxicity, because if it has happened in elderly patients, you hardly know whether the CAR T is the cause of the patient becoming neurotic. So you really don't. But I suppose that is something which is written in literature. So this is how you grade CRS. I will skip the slides quickly, and this is your for ICANS for the neurological problems. So as I said, BCMA is a very important. Once we start targeting the T cells, the search for the ideal tumor antigen goes on. And perhaps in acute myeloid leukemia, we are lagging behind because most of the antigens that we are searching is also replicable on the hematopoietic stem cells. So, maybe that is the reason why, one of the reasons why an AML CAR is not coming along that much well. Though the Lewis antigen and CD71 looks to be very promising. So let's see what that comes out to be. So BCMA, well, on the other hand, is expressed specifically on plasma cells, myeloma cells, and sometimes on epithelial cells, especially the corneal epithelial cells. And it has a key role in maturation differentiation of B cells. So B cells become plasma cells to secrete immunoglobulin. And as they are growing, your BCMA expression on the surface increases. So, BCMA can be a biomarker in that way to see if there are plasma cells there. So it can be, if the soluble BCMA can be used as a biomarker for relapse in myeloma also. So we need to keep that in mind. So that's something very interesting. So BCMA belongs to the TNF alpha superfamily, which have got those other ones also. And as I said, the expression of BCMA increases with progression from MGUS to advanced myeloma. So, we can use this, just, the coming out from the CAR T saying, we can just use this in clinical practice to predict who is going to develop myeloma from MGUS. It's worth a study to look into it with a lot of proteomics in it. I think it is worth a study as to, to specifically look at this protein in the blood. So BCMA, we have been targeting with lots of things. The antibody drug conjugates called belantamab. We've got the bispecific antibodies, of which, teclistamab is a trial we are starting in our institute very soon. And we have got the CAR T cell therapy, which is my ID cell and my CITA-cell. Now, these are the two FDA approved, but in our institute, we are collaborating with a company called Origin, which is for Dr. Reddy's research and referral arm, and we are starting a trial, a phase 1 trial on BCMA antigen for CAR T cell therapy for multiple myeloma. But these are the two which have been approved by FDA, and this is the ID cell data, and it works even patients who have been multiply treated. So that is very good. But I still feel the Johnson Johnson product is a little bit better because with a much lower dose. Remember, in a multiple myeloma patients, it is difficult to get lymphocytes in apheresis. So the dose required in this is less, and I've got two domains targeting the BCMA antigen, not one. And maybe these are the reasons why this product has got a better overall response rate compared to the Idicel. But both are good, both works. If we are successful in the trial, we will see how we go because it's a product which is being developed um, in collaboration in India itself. So, it has a little bit way to go before we say how good it is working. But these are the two commercially available products also available in our institute. Uh, so this is the CARTITUDE trial, and we can see with 27-month progression-free survival of 54.9% in a multiply treated multiple myeloma. I think this is very good. And looking at overall survival of almost 70%, and 3-4 lines treated here. So, so the question that happens is that if CAR T cells are working so well here, why not bring it a bit forward in the treatment of multiple myeloma? And I think that the further CARTITUDE trials, the CARTITUDE 2, CARTITUDE 3, 5, 6, they have gone up to almost 6 now. They are going to answer some of the questions that if I really have a high risk multiple myeloma. A few days ago, I had an elderly 70-year-old man who was a hockey player, ex-Indian national team hockey player, and he had myeloma in the brain. He had a translocation 1416, a chromosome 1 deletion. So I think, an elderly patient presenting with such a high risk myeloma, and your T cells have not gone very dysfunctional with the treatment, not much time. Those are patients where we should try CAR T cell even in the upfront setting. But it is going to be very expensive. So what I've talked so far is two adult scenarios of lymphomas and myelomas. We're just going to talk a little bit more about the pediatric situation. So this is a 9-year-old boy who presents with BALL, CD19 positive, treated with BFM95, isolated with a CRLF2 mutation and translocation 119. My experience has been that most of them will have a CNS relapse in 1 or 2 years. That has been my experience. I don't know, my pediatric hematologists still say that no, we give them chemotherapy, we intensify the chemotherapy, and most of them get better. But I personally feel that all of them within 2 to 3 years they come in with a relapse, and most of the time it is an isolated CNS. So anyway, this boy was again treated with a R3 UK MRC protocol, relapse protocol, where they used lots of bortezomib and mitoxantrone and whatnot. And this time he relapses. So the question now is, what do I do? Do I go in, give him some antibody-based treatment? We now know that inotuzumab is there with us, blinatumomab with us, and we have used daratumumab in some where patients have been unable to use or purchase blin or I know, because of the cost factor that we have used daratumumab in this patient also. Daratumumab expression in B cell ALL is a little bit of a hide and seek game. So, if you're going to give daratumumab before each administration, I would definitely recommend that you check your daratumumab expression on the surface. Because sometimes it is there and sometimes it's not. So there have been some cases where they have tried to induce daratumumab expression on the surface by giving them ATRA. But clinical trials have not been very good because ATRA causes a lot of differentiation, even in AL. So that is something we need to be worried about. The other problem of using daratumumab, I've used it in around 4 or 5 patients and then gone into a transplant. Some of them have done very well. Two of them had very bad GVHD, with one dying of grade 4 graft versus host disease. Daratumumab will activate the T cells. So that we have to be very careful about when we're using Dara as an antibody for such things. So, but we've got an antibody here, which is CD19, and CD19 is expressed in almost pan expression of CD19s in the B cell, starting from the very nascent phase to the mature B cell, and it is not expressed on the stem cells. So this is something we have got an antibody on when the first CAR T trials were on that. But before that, what we had was my blinatumomab, which is a bispecific antibody, bringing my T cells close to the blast, so that you have got a direct cytotoxicity. And we do get, I've used a lot of blinatumomab not only in ALL setting, I've used it in diffuse large B cell lymphomas also. It is a drug which can be given properly. And apart from this girl called Faria, she also had CRS with this blinatumomab also. So if your blast percentage is not very high and you want to go into a transplant or something like that, blin is a very good bridging agent. Uh, so we this is something which has got very little toxicity apart from CRS, and we give it patients lie down. So the infusion therapy, and unlike the West, we want our patients to stay in hospital because that's how our hospital is going to get money. Whereas in the West, it is you get the patients out as much as you can. So it's completely different. So we don't have a problem with the blinatumomab patients lying there and having continuous infusion with it. So I think this is something which we can definitely think of, and so is in inotuzumab. But the problem with inotuzumab is that we really have to wait 6 weeks before, or 4 to 6 weeks before we go on to an allogeneic transplant to prevent VOD. I must tell you that there has been we have written a poster to ASH this time, where we are trying to predict the risk of veno-occlusive disease in transplant by some pre-transplant parameters. And this we are doing by machine learning. So we've written a poster, further working on it. Let's see how we go. But even in that, we find that inotuzumab is one of the major factors for causing veno-occlusive disease of the liver. So we have to be very careful with inotuzumab and the liver. So even though we have those antibodies, we still need a CAR T because we need a long-term remission rate, and the median overall survival with both blinatumomab and inotuzumab lies low. So do we go for an allo transplant after the blin, or do we go for CAR T cell therapy? So, or do we do both? So that is something where we are still unclear as to where we put CAR T or allogeneic transplant in the patient's timeline of treatment. But these two have been approved by FDA for the treatment of acute lymphoblastic leukemia. So as I said, why do we fit CAR T cell therapy into the current treatment algorithm of acute lymphoblastic leukemia? So I get a relapsed refractory patient. I can treat them with inotuzumab or osigomycin. Here itself, I can put CAR T cell therapy. If they're primary refractory, I don't have to think of blin or I can go into that. But remember, the problem here is you're getting a patient who is very unwell, and you are going to spend 3 to 4 weeks in preparing the CAR T if you get some proper lymphocytes out at that point. So sometimes it is not technically possible, or the patient is too unwell to do an apheresis, or the patient hasn't got too much T cells, and I need to treat the patient first. So if I treat the patient with this, then do I do a CAR T there, or do I do an allogeneic transplant? Says if it's relapsed refractory, you do CAR T. If it's in remission, you do allogeneic transplant. I think this is interchangeable. You really don't know which to do when or what. The risk with CAR T cell therapy is it is not risk-free. As we say, we are talking about allogenic transplant being risky. I wouldn't say CAR T cell therapy is risk free. Maybe the risk of neutropenic sepsis is a little bit less with CAR T cell therapy initially, though the people do get prolonged cytopenias with it, and further neutropenia and sepsis. But initially, the counts come up quicker than an allogenic transplant. And the other important aspect of not doing an allogenic transplant is this is an autologous CAR T. So I don't have my immunosuppression problems here. But saying that, there are different ways of doing allogenic transplant nowadays. If I use a Clinimax and I do a CD alpha beta depleted allogenic transplant, I don't need any further immunosuppression. Which is debatable, and we don't have the answer as. So this is another one which says, how do you treat if you have a high disease burden or low disease burden? So this is for the bridging therapy. As I was saying, that if you've got here, then if you're going to go for CAR T, what are you going to bridge with? So if you're going to bridge with, let's say, vincristine and dexamethasone, which I would most probably do, and I would most probably do that, is the patient going to respond? That I can only do in a low disease burden treatment. So for example, the boy that I had shown before, they've got only CNS disease. Maybe I'm fine by doing a low intensity bridging. But if I've got a high intensity bridging, only Vinc and Dex might not work. So there I'll have to think about something else. It is better to leave the CD antigen antibody out if you're going to think of a CD19 CAR and use something like inotuzumab. So these are the outcomes of tisagen. So for this is a Novartis project. So this is the outcome which is coming along, and seeing. And we're getting good event-free survival of almost 50%. But can I not match it with allogenic transplant? I think we can. But again, there are patients whom allogenic transplant might not be fit, and they're only there that we get. CAR T is something very important to keep in our armory at that point. And patients relapse post-CAR T. And if the patient relapse, sometimes they are CD19 negative because you have messed up with that antigen so much that they are fed up with that antigen, and the cancer cell says, "Fine, I forget about CD19. I will go and do something else." So to prevent that, the new concept that is coming along is to do a dual CAR. So you've got a CD19 domain and you've got a CD22 domain. So a dual CAR for. So let's see again. Those are trials which are supposed to happen, and we take it from there with the trial data. So the indications is one of the most important thing is we need to refer early, okay? And that is one of the most. So a patient who is very unwell, and I want to do a CAR T on that, perhaps the patient should have been referred a bit earlier. We don't really treat ALL with T cell depleting chemo, but remember in the myeloma or if we are going to do AMLs, bendamustine and cladribine, if we have treated, then our T cells are not enough to do a CAR T procedure on that. So that is something we need to do. How many doses of CAR T? One dose, two dose, that is something we need to think of. You see, if one dose is costing me so much, how much will the double dose cost? Can we get double dose from a single apheresis collection? Will my price go down? Again, these are all things which needs to be addressed by trials. Remember, the CAR T trials that we have seen so far have been done in places where money was not an issue. So we have to redesign our trials in such a way that we can answer these questions. One of the major questions to answer is about relapse and further complications. So I cannot let a 9-year-old boy have immunoglobulin all his life. That is not possible. So all these things needs to be looked in when we are doing our trials. In the NHS, it's very easy. The patient comes into daycare, has immunoglobulin, goes away. But I am talking about a private patient here who's going to spend who has already spent so much on CAR-T, and you're going to tell them that you spend so much money on IVIG replacement from now on till the boy lives. So that is not practically feasible. Yeah, yeah, sure. Sounds stupid because is making the car. It is very much so. So when you're preparing the car, if you are looking at potentially multiple doses, is it possible to prepare and keep some? Exactly. So that is something. So if we can do something and cryopreserve, right, and then use it if the patient relapses again. But then again, what I'll be doing is I'll be using a CD19 card. If the patient relapses without a CD19 antigen, then we are it's no use. And even cryopreservation iron would cost you money. So all these things need to be addressed in our setting. It is very good to have trials on the Western data where either insurance or state-based, health services take care of most things. But when it comes to individual-based health service, individually priced or uh, at that time, I think it's difficult to replicate all that is happening in the West. So those are the issues that we need to think of in the CAR T cell therapy for an acute lymphoblastic leukemia patient. A 10-year-old boy with relapsed acute myeloid, big chap, 45 kgs, refused by many centers. We give them induction chemotherapy. We have come out from Donorubis and Aracy for induction. We are using venetoclax and decitabine for all age groups, and I find that it is more tolerable and definitely as equally effective as DA. And even in the relapse setting, I am not going into flag IDA or anything like that. We're giving a trial of venetoclax based therapy, and mainly with decitabine. There are a very limited amount of patients where we are seeing venetoclax resistance, but that number is very limited. So, of all that, I've seen most really one patient who hasn't responded to venetoclax. So it is there, it is known in literature, but not much of a practical problem. So we do an allogeneic transplant, again the same thing, but we collect the seeds from the donor this time, and we give the wheat killer here. And in this wheat killer, we must say my friend Ian helps me a lot because he has got a champion wheat killer called total body irradiation. And what we have tried to do is that especially in the AML patients, we do a PET scan when they come. And if we don't see any visceral disease, we would want to give them total marrow irradiation, thereby reducing the complications of organ damage with a total body irradiation. And we have done quite well even in haploidentical transplants. We've done around 10, 12 patients with TMI right now. Even low dose TMI helps in engraftment. So that is something very good. And Oyan has got a good machine called tomotherapy. Do you want to tell us a little bit about your tomo? I mean, it's a little, you have this booklet there. That's the radiotherapy machine that we're using in the Kolkata Center, and that's what the is mentioning. It will not look like the radiotherapy machines that you have here because this is structured quite differently. The beauty of this machine is that this is built more like a CT scan. So what happens is we treat the entire body or the entire bone marrow, and the patient slides in and slides out after the treatment like a CT scan. So it treats with a fan beam like a Japanese fan, and the entire treatment is modulated like your IMRT treatment that you have here, but it is from head to toe. So you don't have any junctions anywhere in the body because if you look at any conventional CR like the one you have here, it opens only 40 centimeters. So if you take an average individual, even if it is a small child, you can never fit a total body or a total marrow into 40 centimeter length, right? So what happens is you use multiple fields of 40 centimeter and trying to cover the whole body or the whole marrow. And whenever there is a junction between multiple fields, what happens with a patient is that the junction, either there might be an overlap resulting in a higher dose than what you are planning, so therefore that might be toxic, or there might be a little bit of gap between cancer cells remaining in the body and the cancer cells that are being destroyed.
junctions. And if you have a radiotherapy system which basically treats the entire body in one go, it is a fantastic delivery system for TBIs, TMIs, craniospinals for your medulloblastoma children, and so on. Large fields, right? So this is one of the world's best IGRT systems. We are very proud to have the first such machine in India in our hospital. And that's why, Dada also gets the confidence of, referring all his CDI and PMI patients for low dose transplants with a high dose. I mean, high dose radiotherapy as preparation for that.
Okay, so thank you. So this is, but we need the match, and as we're going along, we've just got one child in the family. We rather use the haploidentical match from a mother or a father. So that's half a match. And we use this because we want to use all the cells to go and kill the cancer cells. But we know that this kind of cells would also target the other organs and give rise to the graft versus host disease. So is there a way by which we can increase the GVHD and increase the GVL effect? And that way is one of the ways is by using this machine called Clinimax. And we have this in-house in our institute. And what we do is we take out the alpha beta T cells with electromagnetic beat separation, and we keep the gamma delta T cells here. So you can see in this patient we have taken out the alpha beta T cells, and we've kept the gamma delta T cells in. This is a child, works better for the child because uh, because of mainly the stem cell dose from a parent to a child and the weight difference rather than anything else. So this is a gamma delta T cells dose here. Also, what we do is we take some MDLI or the CD45RA depleted memory cells, as donor lymphocyte infusion, and keep it. And because they are naive T cells depleted, the chance of having graft versus host disease is definitely much less than normal donor lymphocyte infusion. So we use this, and we did it in that boy. The boy is doing well. And with this, what happened is we used that MDLI in this patient. So this man had had a transplant with using the Clinimax. On day plus 14, he had a Delta variant COVID. And then we had those MDLIs with us, and we gave it to the patient. So it is very useful in the patients, not only for COVID, but also for other viral infections. And also we can keep the DLI in place with us if the patient is relapsing. So for example, another girl, 14-year-old Tiasha, her chimerism went down to 80. She had COVID. She was completely asymptomatic. She had gone home and had COVID, and she was completely asymptomatic. And then we saw her chimerisms were dropping. And even, after stopping she was not on any immunosuppression at all. So we had some DLIs with us, some MDLIs, and we gave it to them. So this is something really nice to have with us when the patient is unwell post-transplant, either because of a relapse or because of any viral infection. BK virus infection, we find that everybody who's having a haploidentical transplant in India is having a BK virus infection. So we have been carrying this BK virus in our bladder for a long time, I feel. And once we get immunosuppressed, it comes out. I think that is what is happening. And that is perhaps more than what the Western people carry in their bladder. So anybody we are doing a haplo is having some form of BK virus. Only one might be a grade 4 that I have seen, but generally speaking, a grade 2 kind of a hemorrhagic cystitis that we are seeing. So, this is something which we can think of during BK virus. There are, better ways of use. So, we have antiviral T cells also, which we can manufacture with the Clinimax, which will be just against the virus. But if we don't have it, again, this is going to take us 2 to 3 weeks to. This is a interferon gamma based method. So we see that the donor lymphocytes are targeting a lot of or secreting a lot of interferon gamma. Then we culture the antigen with the the cells with the antigen, and then we grow the cells and then give it back. It will take some time to grow. But in the meantime, if you have MDLI with us, we can we've gone a long time. If we have the this thing with us, we can use it for viral infection also. The other thing where we can use the Clinimax is the NK cell therapy. So NK cell therapy, I personally have been very interested in for a long time, and what we find is we used to use this in the T deplete haplos. So pan T deplete haplos, we used to get some NK cell therapy and we used to give them infusion, 3 or 4 NK cell infusion, with the hope that it is going to prevent a relapse and also prevent bad infections just peri-transplant period. But then we have come out of that. We're doing, alpha beta T cell depleted. We can still give NK cell infusion with that. The question that happens is that can you use NK cell infusion on its own? And maybe we should do it on a basis of a clinical trial. Remember, there are many cells which are going to suppress the natural killer cells activity. So we need to get rid of them first. So we use bendamustine first and then give the NK cells. Okay, we give the patient on lenalidomide and dasatinib, which suppresses my myeloid-derived suppressor cells, and it also suppresses my T regulatory cells. After that, I give the NK cells. There's another thing called the hormone melatonin that also suppresses my myeloid-derived suppressor cells. So we give them melatonin tablets. Is now available freely. So we give them melatonin tablets and done that. So we've done 2 cases like that on the basis of a clinical trial. One was a CML blast crisis who didn't do well, died. The other one was a AML who was doing very well, touch wood so far. So this is the curl ligand mismatch of that. So as I said, we've done 2 cases with that. So that's about it. I should have. I don't think I've got anything else to talk about now. Okay. So what I've basically tried is to try and see realistically how we can use CAR T cell therapy in our economic setting where the patient is himself paying and it's not being paid by any other source. How practical that is, we need to design trials on our own with that. And also the